Hi, it's John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn, coming to you live from the Mass Medical Society in Waltham on location today. On this beautiful Thursday, we're happy to welcome Dr. Jordan Glicksman to come talk to us about sinus cases, what I want you to know. Thanks, Jordan, for being here. Go ahead and advance to the next slide. Want to just tease our upcoming lunch and learns. Next week, we have a family doc coming, Dr. James Bath, who I've known for a long time. He's going to be talking to us about autism and patient care and transition planning, which I'm excited about. And then following week, we have new therapies in atopic dermatitis and eczema. Dr. Michael Crathen will come back and talk to us about that. Just as a reminder, we have all these talks are archived up on our intranet. They're also archived up on YouTube by simply searching Newton-Wellesley Medical Group Lunch and Learn. Next slide. We wanted to remind folks a couple of announcements before we let Dr. Glicksman take on. The first is that Newton-Wellesley Hospital is celebrating Patient Experience Week, April 25th to the 29th. Special messages of thanks and chicken noodle soup recipe for all our inpatients. We'll have a slideshow as well on Newton and some social media recognition. So don't forget to take that time to thank your patients for choosing Newton-Wellesley Hospital. Here's a sample of that home-style chicken noodle soup recipe. Next slide. And we gave away a lot of these bottles, and I've been using mine pretty regularly. It's a pretty good bottle. Go ahead, and we still have some left. So please, from Doctor's Day 2022, we want to get them in your hands. So please contact Kathy Servan in the Office of Experience. She'll be able to get that to you. Next slide. And we've been teasing this. This access goes through November. This is +1 access for you and a significant other. This is a great service for you to get information about anything, anything that you need to get done. It's a valet service. If you're looking for someone who can cut your lawn or to get your lawn up to speed or to help you pick out a good Mother's Day gift or to find a good vacation spot, they will do all the research for you. It's pretty non-invasive, and you're welcome to go ahead and use that. They'll send you all their responses by email and even help you set up appointments for your house, so for any kind of appointments that you would need. So please go ahead and log on. Please, you can enroll at communities.circles.com and with the welcome code NWH. These services are around for you. They are paid for, so please take advantage of them. Next slide. I think that's it, Jordan. Oh, one more. Sorry. Yeah, Pay It Forward is one of our greater programs that we are giving way to acknowledge one of your colleagues. One of your colleagues does something really nice for you. Let's say Jordan takes good care of one of my patients. I could pay it forward to him, send him a nice note, send it along to Kathy Servan at that email address, and he will then be the recipient of a $100 gift card. And then if he turns around and says, hey, this doctor did something nice for me with one of my patients, and then he forwards it along. That's our Pay It Forward program. We have funds are still available. We have these gift cards. We want to give them to you. Please go ahead and take advantage of this program. Next slide. And all yours, Jordan. Thanks.
All right. Thanks for the introduction. I appreciate it. And thanks to everyone that showed up. I'm on location in Florida on vacation. And I hope that you guys are having nice sunny weather like we're having here. Yeah, so today's talk, I called it Interesting Sinus Cases. What I want you to know is, and what I realized actually was that it's all unilateral nasal cases. And you'll see some themes that recur throughout. And hopefully some of this will help with your patients as they come through your practice, as you might see some of these interesting type of problems come through. So just a reminder, our group is based in Newton-Wellesley. We're in the White Building. We have 2 suites across from each other. One of them is where we take care of our patients. We have Dr. Alifas, myself, and Johanna Lam, who's our nurse practitioner. Then we have some audiologists that come in and help with our patients that have hearing problems. But today we're talking about the nose. So when we talk about sinus disease, we most commonly consider acute and chronic sinusitis. And I've given a talk on that previously, and it's on the YouTube page, so you can go back and look at that. That's not going to be the main focus of today's talk, but please feel free to check it out. Today I'm going to introduce you to some conditions of the sinuses that are a little bit different, but still in the case of all of them, I think important to know about. So just a quick refresher, the F is where the frontal sinus sits, the septum is where the S is. We're moving our way further back in the nose, we've got the maxillary sinus labeled with an M, the middle turbinate on the right side labeled with an MT, inferior turbinate with the IT, ethmoid sinuses are between the eyeballs, septum is still in the middle. And as we get further back, we get to the sphenoid sinus. And then looking at a sagittal cut, you can see the frontal sinus, anterior and posterior ethmoids, sphenoid, and the inferior turbinate shows up as well. Most of sinus disease is focused on this area here called the osteomeatal unit and trying to keep this open so that way you don't get acute or chronic sinusitis. A lot of a lot of these conditions relate to inflammation in this area, which then spreads towards the sinuses. But what I'm going to do today is talk about slightly different variations of sinusitis and also other non-sinusitis type conditions. And you will notice a theme where the patient names are all a hint as to what the condition might be. So our first patient is a 71-year-old woman named FB, comes in with 4 months of facial pain on the left. The dentist was concerned about maxillary sinusitis. Unfortunately, didn't improve with tetracycline, amoxil, Medazone spray, followed up with a colleague of mine and got clindamycin and more nasal sprays. Couldn't recall which ones they were and just wasn't getting better. Current symptoms when they saw me were maxillary pressure and pain, post-nasal drip, foul odor in the nose. They had not been on oral steroids yet. There was no asthma, no allergies or frequent sinus infections, and no prior sinus surgery. And so I went ahead and I got a CAT scan. I'll show you what the endoscopic view looked like a little bit later, but this is what their CAT scan looked like. And you can see there's a little bit of an irregularity here where you've got a little bit of a different density relative to the other areas. And so this could be considered double density, which is characteristic of a problem with the initials FB, but there's also a differential diagnosis. So fungal ball is what I suspected this to be, but it could just be acute maxillary sinusitis. We don't see the teeth, but it could have been odontogenic in origin. It could have been neoplasm. Allergic fungal sinusitis can look like this as well. And granulomatous disease can present in a similar way also. I went on to get an MRI. This is a 71-year-old patient, didn't want to go under multiple surgeries. And because there still was a differential diagnosis, getting an MRI was very helpful because it showed us that there was this area of, this is a T1 contrast coronal cut of at the level of the maxillary sinuses. You can see there's a little bit of inflammation, not terrible, around the maxillary sinus, and then this area here where it's not taking up any contrast. And so there wasn't an obvious enhancing mass, and I felt that it was reasonable to go forward under the assumption that this was going to be a fungal ball. The thing is that with unilateral sinus findings that don't respond to medical management, we pretty much always recommend surgery as a next step. The differential diagnosis includes conditions, for the most part, that don't respond well to medical therapy: fungal sinusitis, neoplasms, and granulomatous disease. None of these will respond well to medical therapy for the most part. Although granulomatous disease, there are ways to help things. Often you have to open up the sinuses. So this is an operative video, which will give you a sense of what the physical exam looked like when I scoped this patient in the office. And I'm just going to run through this video quickly. I hope that it comes through nicely and that you can see it. So you can see here that's the uncinate process that I'm pushing against with the suction. You can see a little bit of pus up high. And I go here and I make some injections so that way we don't get as much bleeding when we go forward with the surgery. But you can see that uncinate process is kind of pushing out, and that'll be in contrast to another case that we're going to see shortly. So I'm making my injections there, trying to give myself some more space by moving the turbinates around a little bit, and giving myself a bit of a quarter within which to work. And then as I push on the uncinate process, you can see this fungus and pus coming out, and my seeker just drops right into the maxillary sinus. Usually I wouldn't go in like that with it. I would just try and find the uncinate with it and then come back with this backbiter and open it. But my probe just fell right into the sinus. It was very obvious that we were in. So here we are freeing up the uncinate process, grabbing it with a Blakeslee forceps and pushing it back and then pulling it out. And then now we are sitting here with a really widely open maxillary sinus. And the next 15 minutes was spent trying to get this fungus or fungal ball taken out of the maxillary sinus. And you can imagine how uncomfortable that would be for the patient to be sitting there. That's basically the bulk of this case. I just spent the rest of the time trying to clean up the sinus and making sure that there were no free shards of bone and that sort of thing, and making sure that all the fungus was taken out and that there was no secondary infection. So here we are with a microdebrider, which shaves and cuts and just cleaning things up. And you can see now the maxillary sinus, it actually doesn't look that inflamed, relatively speaking. This isn't really an infection. It's more of a fungus that it has an opportunity to grow and a fungal overgrowth, essentially. And then I put in a little bit of a hemostatic agent. I promise you that's not a nefarious substance, and clean things up. And that's pretty much the end of the case. And we have a nice open maxillary sinus, no fungus left. The patient can do saline irrigations, and they're pretty much going to be on their way. And just a little bit about fungal balls for some background. This tends to happen in immunocompetent patients as opposed to invasive fungal disease. It's a non-invasive fungus. It's a collection of mucus and fungus without a major immune response. You get that double density on CT, and the MRI, as I mentioned before, can be helpful when the diagnosis is unclear, and it can potentially prevent the patient from having to worry about having a second operation because you go in and you find a tumor and you're going in for a different reason. Treatment is surgery. Steroids can help as an adjunct. I didn't use steroids in the case of this patient post-operatively, and oral and topical antifungals just don't work. And fortunately, these don't usually recur. I've had one that came back and we just cleaned it out in the office and that was the end of it. But generally speaking, surgery and then they're done. So I'm going to move on to my second patient. This is patient IP. Again, another hint in the name. This is a 40-year-old male with 2 years of right facial pressure, right nasal obstruction, nasal congestion, thick nasal secretions, and thinks he sees a polyp on the right side. Has been treated with saline rinses, topical steroids, multiple courses of antibiotics, no prior surgery. He does have asthma, but no reaction to NSAIDs, alcohol, or aspirin. And this is what we see on the endoscopic exam on the right side. And just trust me when I say the left side looked perfect. So the question becomes, what's the next step? And this is, I think, an important teaching point in this lecture. We need a diagnosis as to what this is. And we always obtain imaging before we go ahead and we do a biopsy. And the reason for this is because of some potential problems that we can find, vascular lesions and also encephaloceles, and we'll talk about encephalocele a little bit later in the day. But in this case, you can see that there's a right-sided enhancement, sorry, not enhancement, there's a right-sided opacification in the maxillary sinus, and it looks almost pretty similar, except there's no double density. And this is a mass now instead of it being a fungal ball. And the biopsy, which we were then comfortable doing after we had the CAT scan and knew it was safe, showed an inverted papilloma. An inverted papilloma is a benign nasal tumor. It has about a 10% conversion to squamous cell carcinoma at about 10 years. And the treatment is surgical resection and surveillance. And if we catch these things early, they don't turn into cancer, and we can watch them and make sure they don't grow back. And if they do, we can go back and take them out again. So this is an operative video here. And you can get a sense of what we do. So I start out by trying to map the tumor and get a sense of where things are attached and where we can take it out from its point of attachment. So that was the scan there. And you can see here, we're kind of going along and figuring out, okay, here it is. The septum's on the right and it's not attached there. So we can take the tissue medially. We don't have to take it in one piece. We can take it in piecemeal. As long as we get the main attachment, it's safe to do that. And so here we are, we can see that it doesn't have a superior attachment. And from the CAT scan going in, we expected that it was attached to the lateral wall of the the lateral wall of the nasal cavity, or medial wall of the maxillary sinus, which is a common attachment point. So because of this, we decided we're going to take down that wall, and this makes the procedure an endoscopic medial maxillectomy. So here we are taking down that wall. I'm trying to save the mucosa that's healthy there and not involved with tumor on this side of the nose. And I'm raising a flap because I'm eventually going to drill down the bone in that area. And by drilling down that bone, I'm taking out the attachment point. And then we can reline it with this mucosa that I just raised. And so you can see we're now approaching into the maxillary sinus from below the inferior turbinate, which has been resected. This is really getting at where the tumor is attached. We also thought that it might have been invading into the nasolacrimal duct, which is the tear duct, and we made some efforts to open that up as well, as you'll see. But here we are. At this point, the bulk of the tumor has been removed. Here we are doing a little bit of work on the nasolacrimal duct, making sure that it's nice and open, patent. So that way the tear duct, which could have potentially been blocked by tumor, has a place to drain. And here we are taking out the blood supply to the inferior turbinate and making sure that it doesn't bleed there. And then that's the end of the case. So nasal tumors are uncommon. I'm not going to go into a full differential diagnosis because that's something that once they come to us, we usually take care of. But suffice it to say that the most common benign tumor is an inverted papilloma, and the most common malignant tumor is a squamous cell carcinoma. And the real take-home point is don't just biopsy these in the office. It's really important to get imaging first, and then the treatment will really depend on the pathology, as well as the stage and the location, and how amenable it is to resection. Case 3, patient SS, again, another hint. in the names. This is a 36-year-old, another ENT sent from Western Mass, diagnosed due to visual disturbances and difficulty focusing her eyes, had enophthalmos or a sunken in eye on the left, a remote history of a motor vehicle collision in 2014 with facial trauma, had mild nasal congestion, but otherwise no nasal symptoms. No risk factors otherwise, except for some allergies to trees, grass, and her cat, but did have that motor vehicle collision that I mentioned before, which will become important. And this is not my patient. Out of respect, I took a picture of a patient with this condition from Google Images. This is someone from a Lifetime show called Dance Moms. Chloe, I'm gonna butcher it, but she had this condition and was relatively public about it, so I pulled the images down. But you can see that the patient has enophthalmos, and their eye on the right, which is the opposite of my case. It was on the left. Looks like it's a little bit lower than the contralateral side. And you can see on my patient, patient SS's CAT scan, this exact appearance where the orbit is coming down lower on the left side than the right. And this is a condition called silent sinus syndrome. When we go in to do surgery to fix these patients, we have to take great care not to enter into the orbit because there definitely are patients that have had orbital injury from someone not either noticing where they were or other misadventure. So it's a disease of the maxillary sinus. It's most common in middle age, and it has other names, one of which is really awesome, and that's why I included it, called imploding antrum. And this is a more descriptive name, chronic maxillary sinus atelectasis. You can see that the sinus is really atelectatic. It's a lot smaller than the other side, and that's what's allowing the eye to come down. The orbit enlarges, enophthalmos develops, you can get cosmetic consequences, and then visual changes can follow. And there's often a history of head trauma, as was the case in my patient. Treatment is surgical, and as I mentioned, we got to be careful to not injure the eye. And here is my operative video. So this is just showing you the image guidance where we're trying to get to open it. This patient also had a septal spur right here, which we will at some point take out before we continue with the case. Unlike the other case where you could see the unsnip process was pushing out, you can see it's actually sucked back in, and that creates a situation where it creates that vacuum that allows that sinus to get smaller. I'm doing my regular injections, and now I'm taking care of the septal spur just to give myself a little bit more space to operate. Pretty simple to address those. And then we take a lot more care. You'll recall I just sunk right in with my seeker in that other case into the maxillary sinus. And here I take a lot more care, a lot more caution, because I don't want to enter the orbit. I'm always careful, but this is, we got to be particularly careful. So instead of popping right into the maxillary sinus, I just identify where the unsnip process is. I come back with my backbiter, take a couple chomps coming from posterior to anterior. And then I try sometimes to go a little bit superior as well to really free it up nicely before removing the unsnip process, which blocks off the maxillary sinus. And we kind of free it like in a postage stamp type style. You can see here, this is not pus. This is just trapped secretions that have been there for years, and they're very thick, but very different in character compared to that fungus that we saw in the first case. And the unsnip process is removed, and the bulk of the case has now been done. So that unsnip's now been removed, and we have a nice opening into the maxillary sinus, which is a lot smaller than the other side would be if we had opened that one up. I'm not going to go much further. And, basically, we clean up the edges and just make sure it's nice and open. But that should suffice it for this case, since we're going to run low on time. But you can get a sense of what's going on there with that sinus now being open and the vacuum being released. So the patient had cosmetic concerns. I'm going to have them see a cosmetic surgeon. I just operated on them last month or the month before, and they're going to see about having their eye lifted back up, like Chloe from Dance Moms did. And then patient number 4, this is also, I think, an important unilateral sinus disease situation. This is patient EM, a 60-year-old female that was admitted. This is back when I was up in Salem on the North Shore, that was admitted with meningitis. It was isolated rhinorrhea on the right side for over a year. Felt like their nose dripped like a faucet. And this was actually their 3rd episode that they were admitted to the hospital with meningitis. They had a past history of some very severe falls, and they're coming in with meningitis. The meningitis at this point had been settled, and they're just trying to figure out, what's going on and why does this patient have dripping from their nose on one side. So test to order, if this was in person, I'd be able to poll the audience and just pretend that I'm asking you the question. Beta-2 transferrin, CT scan, and MRI are the three tests in a case like this that I'm thinking about. I'm thinking about a CSF leak. CSF is a place where you can find beta-2 transferrin. It was positive in this patient. The only other places it can be is the paralymph and vitreous humor. Paralymph is in the inner ear. Vitreous humor, as we know, is in the eye. And that's a pretty good marker that this patient has a CSF leak. So I had to look at the CAT scans and MRIs that they had done in hospital prior to my meeting the patient. And you can see here, this is a cribriform plate. It should be coming across like this. And there's an asymmetry here. And on the right side, it's a lot thicker than the left. And that's the side they're having their drip from. So right there. And then on the MRI, if we zoom in, it becomes pretty obvious that there's some CSF density right here on the right side. And that's an encephalocele. So this is an encephalocele with a CSF leak, and then they've had meningitis 3 times, and the CSF leak went unnoticed, and so did the encephalocele until we came along, and our goal was to repair it. So encephalocele is a protrusion of the brain through the skull, or you can also get meningocele through the spinal cord. They can be congenital or acquired, and we will encounter them in any of the sinuses and also the nasal cavity. And they can also involve the orbit, although I've not seen that personally. Risk factors, so congenital folic acid deficiency is a big risk factor, and then trauma, surgery, and elevated intracranial pressure are the big causes. This is another good reason not to biopsy a unilateral mass before imaging. You don't want to biopsy an encephalocele because that can cause a leak, which can make it so that we have to do your surgery faster to repair it, and also give them the risk of meningitis. But then also more, just as, or maybe even more importantly, a blood vessel can be coming down through the encephalocele, and then when you biopsy it, it can retract. And if it retracts, you're going to get a hemorrhagic stroke, and that's definitely been described. And actually, I know of one case from, I trained in Canada during residency. I know of one case at a nearby hospital where that happened, and it was terrible. These patients tend to have rhinorrhea where it leaks like a faucet. It's usually unilateral, and it's worse with Valsalva or bending forward. They'll have a salty or metallic taste. And there's something called the halo sign. We see this with trauma or with nosebleeds, I guess, if they have a nosebleed too, where the blood is typically in the center and then the CSF goes to the outside. And then they can present with meningitis, or this is the case in my fellowship where a patient had terrible pneumocephalus, and it was really tragic. They ended up doing okay, but it took them like a year to recover back to their normal self. It was awful. And you can see here the encephalocele protruding down and how bad. This is the worst pneumocephalus I've ever seen. These are patients when they're going to sleep. We don't let them bag mask them because we don't want to push air up into the sinuses. So repair is surgical. Usually we do it through the nose. If the patient has intracranial hypertension, then I'll send them to a neurologist for management. Often we'll do intrathecal fluorescein to help label these things. And so we can get a sense of their opening pressure and know if they've got intracranial hypertension. And then weight loss and acetazolamide are the main treatments there. And then here's my operative video for this patient. So you can see the imaging that we've previously referenced. And here we are. So we take out the middle turbinate, and I save this, and I actually mark the mucosal surface so I know which side's mucosa, which side's on the inside for later. And then there's your encephalocele, and it's labeled a little. You can see it's a little bit more yellow there, and that's from the intrathecal fluorescein. I use a bipolar cautery to ablate the tissue, and in this case, that's all it took to close the CSF leak. And then you can get a sense of where we are here, and you can actually see the brain pulsating right there. And that's what we aim to close. And then there's the frontal sinus heading up in this direction here. So I put a little piece of bone from the middle turbinate there as one layer of closure. And I eventually get it to sit nicely on top. And then once it's sitting nicely, I put some Tisiol on, which is basically a tissue glue. And then here's that labeled mucosa from the middle turbinate to act as a graft. And we use packing to keep it in place once we're happy with where it is. First, some more tissue glue went down though. And we pack off this area so that it holds in place and can heal for a couple of weeks. There's different post-op management protocols that people will do, but I usually try and not disturb that area for at least 2 weeks so it can heal nicely. If the CSF leak was bigger, we could have used a pedicled graft, which has a blood supply, but in this case, because it was small, I didn't think it was necessary. and we pack it off. And fortunately for this patient, the surgery was 5 years ago, and there's been no recurrence. We do have an MRI that was done recently, and this was done not for the purpose of the CSF leak. The patient unfortunately has malignancy, and this is part of their surveillance. And you can see here the skull base is nicely intact and looks nice. And so I don't usually order routine surveillance for these patients, but when you have it, it's nice to be able to put it up on your slideshow. I have one more case. I don't think I'd be able to get through it all, but I'm happy to share it another time with everyone, unless there's no questions, in which case I can put it up as a little bit of a show and tell. Dr. Snyder, are there questions in the forum right now?
Yeah, I don't see any right now, Jordan. People can feel free to throw that in there. One of the things that I'm sitting here thinking about as a primary care doc who sees one-sided sinus pain all the time is, when should I be nervous about some of these cool things you just showed us? I mean, I know if we fail one or two treatments, I'm probably sending them your way. But when are there other things that we should be looking at least in the primary or secondary time, that would make us think, besides some of the things you already mentioned, maybe head trauma, and of course that faucet, that sounds pretty suspicious, the runny nose. I mean, is it one course of treatment, or what kinds of things should we be thinking about as primary care providers that we should be worried about some of these other diagnoses?
Yeah, it's really tough because not all facial pain is sinus disease, although it's tough to convince a lot of patients that they don't have sinus disease, and it often takes a CAT scan and a scope to convince them of that. So I order probably more CAT scans than I'd like to because of that. I think you're in a difficult position because you don't have the scope, and you're probably less likely to pull the trigger on imaging, as you should, to be a steward of the resources and not expose the patients to too much radiation and that sort of thing. So yeah, I guess the big things for me is unilateral nature, not resolving after a course of 2 of antibiotics and or steroids. And if things persist or recur only on one side, those would be kind of red flags that I'd be thinking about. But for what it's worth, we're always happy to see your patients. And if a patient has unilateral disease, there's that, I think it always kind of warrants a little bit of investigation if it doesn't get better relatively quickly.
And then there's one question here about what kind of CT to order. Do you prefer anything? Should we just say CT to evaluate sinuses, or non-contrast, or how does that work?
Yeah, so they don't need contrast typically, unless we're looking for something vascular, and even then, typically the things that we're looking for that are vascular or pathognomonic without contrast. If you're able to order a Medtronic protocol, or if we change our navigation system, it might change to a different protocol. But an image guidance protocol, CT sinus or CT face, that should do it. The only reason that, if you're concerned enough that you're going to order a CAT scan, then it might make sense to send them to us. The challenge is that we don't want to order 2 scans. And if this CAT scan, let's say you get just a CT brain and it's not thin cuts in the right protocol, then when they see us, if they need surgery, then we're ordering a second scan. Not the end of the world because it's not that much radiation. But generally speaking, if you're going to order something because you're thinking about the sinuses, I would say either a CT face or CT head. And I would say, assess for sinusitis, navigation protocol. And if you put that in, the radiologist should be able to figure it out at any of the MGB institutions. And then when they come to see us, if it's necessary, then we'll have the right scan, not have to reorder it, which would be great.
Typically, your order is scoping them in the office first and then CAT scan. So maybe it makes more sense to send them along prior to ordering a CAT scan, I guess.
Yeah, I mean, where I trained in Canada during residency, every patient that came to the Sinus Center had a CAT scan first, but I don't know that's necessarily the best use of resources, the best exposure for radiation, and certainly in our insurance paradigm, that wouldn't be possible. But yeah, I think, typically I'll scope them first. And my previous talk that I gave last time, we showed the difference between the view that we get and the view that you're able to get with your equipment. We have an unfair advantage. So sometimes leaving it to us to decide is helpful. But if you're going to order the test, then we're certainly pleased to have it available.
Sure.
For sure.
All right. Well, listen, coming up on 1 o'clock. Thanks so much. So we want to remind folks about Dr. Friedman's Wednesday morning grand rounds. Always great. We heard a great talk yesterday on lung cancer screening and new really cool AI stuff that's coming down the road. And Jordan, thanks for coming. We'll put this up on the web as we talked about it. We'll have you back to talk about something else. And we'll see everyone. Everyone have a nice weekend. We'll see everyone next Thursday to discuss autism and the transitions of care. Thanks again,
Wonderful.
Jordan.
Thanks for having me.
Okay.
Thank you.
Bye.